Well, thank you for inviting me today to talk with you. This is somewhat of a challenging topic as there's no clear-cut answer, but it is definitely, as Joe said, a very hot topic in radiology. So when we're through today, you should be able to define overdiagnosis and contrast the harms of overdiagnosis with the benefits of screening, and really feel comfortable discussing that with your patients and referring providers. You should be able to estimate the magnitude of overdiagnosis and describe the role of radiologists in managing overdiagnosis. First, a few stats. As you know, breast cancer is the most common cancer in women and the second leading cause of cancer death in women worldwide and in the US. And 12% of women today will be diagnosed with breast cancer during their lifetime. Closer to home, in 2016, nearly 5,000 women were expected to be diagnosed with invasive breast cancer. We're fortunate to live in a state where there's pretty good access to screening mammography, and nearly 80% of women ages 40 or over reported having a mammogram in the past 2 years. As such, you can see there's also a high percentage of women who are diagnosed at an early stage where treatment and survival are much easier. These graphs demonstrate the importance of early detection. As you know, early detection saves lives. When detected at stage 0 or stage 1, survival of breast cancer is in the realm of 90+%. So, breast cancer mortality, along with that great early detection from screening mammography, has been declining. Since 1990, breast cancer mortality has decreased 35%, at least, depending on the studies you look at. This correlates with nearly 250,000 deaths averted due to screening mammography and treatment. So despite all this great news, screening mammography finds itself in the spotlight again and again, and typically in controversial fashion. This was a pretty well-publicized article, and a quote from that: "When directed toward the general U.S. population, the most prominent effect of screening mammography is overdiagnosis." And as a breast imager, that just makes my blood boil. And even if you're not a breast imager but a radiologist, it feels like such a kick in the pants that what we do and what we're trying to accomplish is so diminished and published in a reputable journal. So we're going to talk a little bit more about overdiagnosis and how we can kind of get a handle on that. The first objective is really to define what overdiagnosis is. And overdiagnosis is defined as the screen detection of a breast cancer that would not become clinically apparent during the lifetime of a patient. And this, of course, is not limited to breast cancer. We see it in thyroid and prostate cancer, and even in non-imaging diagnoses like ADHD. So overdiagnosis is a broad term, but we're specifically talking about it today in the context of breast cancer. So does it exist? Well, in 2017, yes, there's general consensus that overdiagnosis exists, and it is a legitimate potential harm of screening mammography. It didn't, my little animated clicks didn't come in. But what is the scope of overdiagnosis? And that's what we really need to talk about. What are the causes of it? The two main causes, the first would be death due to other cause prior to effect from breast cancer. And we see examples of this. This is a case I saw just last month. And I'm sure you all can think of cases of this in your own practice, where a very elderly person or a very debilitated person comes in for screening of their own accord, or a family member brings them in wanting screening mammography. This was a woman who was 77 with stage 4 lung cancer, and she presented for screening mammography. She had no active disease, but of course, still stage 4 lung cancer, and she had a spiculated mass in the right breast. And we can see from a prior mammogram in 2014 that had been there, but is gradually changing. So this kind of suggests to us that this probably isn't a very high-grade cancer, but we can't unsee it. And we're about to unleash a whole cascade of events that once you start, it's so hard to stop, right? So this patient had a diagnostic mammogram, she had an ultrasound, she had an ultrasound-guided biopsy, surgical consult, partial mastectomy, and medical and radiation oncology consults. And even if she didn't go on to have any chemo or radiation therapy, she still had all these steps in her process. And I think we can all agree that this grade 1 cancer poses less threat to her life than her stage 4 lung cancer. So that would be an overdiagnosis by the definition. The second main cause of overdiagnosis is really non-progressive in situ or invasive cancer. And this is really where there's more debate about how much of this exists. For much of the 20th century, we really thought about the natural history of DCIS as kind of a steady march from atypia to DCIS to invasive cancer. And we thought of that as really a steady progression. But now we recognize there's great variability in DCIS and good science that shows us that high-grade DCIS, in most cases, 84%, will be invasive in 5 years. So it's hard to imagine a high-grade DCIS could be considered an overdiagnosis. The treatment and excision of a high-grade DCIS really averts the occurrence of an invasive cancer. In intermediate grade DCIS, we find that most are invasive within 10 years. And low-grade DCIS could be invasive in 15 years or more. So really, when we get down to the low-grade DCIS, we do kind of have to acknowledge that these, by definition, could be overdiagnosed cancers. In the realm of invasive cancer, is there such a thing as an overdiagnosed invasive cancer? Well, to start, there's little evidence of any invasive cancer regressing without treatment. And anecdotally, we see occasional patients who refuse treatment, but still for some reason come back for another mammogram, and those don't magically go away. There's really no evidence of that occurring. We do have data that gives us a median doubling time for invasive breast cancer of 130 days. But similar to DCIS, we now recognize that there's greater variability in invasive cancers also. So in the past, we always thought of breast cancer as kind of a single entity, but today we recognize that there are 5 distinct molecular subtypes. And the prognostic implications of those are so great that they've actually changed the staging of breast cancer. And the 8th edition of Staging journal was published fairly recently and will go into use beginning next January. And it actually takes into account the breast cancer grade, the ER, PR, HER2, and Oncotype score, and really changes significantly what we've traditionally thought of as just the size of the tumor, the node status, and if there's any metastatic disease. So I think we recognize that, yes, overdiagnosis exists, and yes, there is great variability in the type of cancer that we detect on screening mammography. But to what degree? And this is where the water gets really muddy. There's no agreement, and reports are widely variable. Some people will claim there's no such thing as overdiagnosis. Some estimates will give you up to 54%. And why is that? Well, it's because there's no way to directly measure overdiagnosis. It's really an epidemiological concept. And it's estimated, kind of to understand why we get a wide range of variability, to help you understand how authors estimate it. We really have to understand the excess incidence concept and then the disease natural history and lead time. So excess incidence is really the incidence of breast cancer in a screened population compared to the incidence in an unscreened population. And if we know the excess incidence, we can then go on to determine what the rate of overdiagnosis would be. In a perfect world, we would have a randomized controlled trial with an arm of women who were screened and an arm of unscreened women. And then we would have a long enough period at the completion of the screening trial period to then allow catch-up so that we exclude from the excess number any cancers that were actually relevant that were just detected early. In reality, this could never happen in the US because screening is widespread already. We do have several fairly close approximations in Norway and Sweden, which we'll see later on the results of those. Probably the most publicized and well-known estimate of overdiagnosis was published by Dr. Welch in the New England Journal of Medicine in 2012, and he made the assertion that 31% of breast cancers that were found by radiologists in 2008 were overdiagnosed. And a lot of people found that hard to believe, so we had to look to understand if that could possibly be right, at what the possible bias or flaws in his methodology were. First, for his estimate to be accurate, he would need to know a valid estimate of the incidence in the absence of screening. And he did not. He assumed that there was a stable breast cancer incidence prior to the onset of screening, and we know that's not true. Beginning in the 70s, before we even had widespread use of screening mammography, breast cancer incidence was already increasing. So before that, radiologists could have had any impact on the incidence through overdiagnosis, the rate of breast cancer was increasing. And this is attributed to changes in diet, lifestyle, and environmental factors. In addition, he would have needed to allow sufficient follow-up, as I said, to ensure that the excess percentage excluded relevant cancers that were detected early, and they did not include a long enough follow-up time at the completion of their study. So this really goes into or leads into the lead time concept. And so the New England Journal study did not allow enough lead time, and that is the period of time by which screening advances detection. So we see in an unscreened patient, she would remain asymptomatic and undiagnosed until her cancer became clinically apparent. There would be a period of survival prior to her death. A screened patient, we advance the diagnosis, and then she automatically has a longer survival time, even if death is not delayed. But the time between when her cancer was diagnosed by screening and when it would have been diagnosed clinically is the lead time. And if we can get an accurate understanding of what that lead time is, then we can really kind of validate the estimates of excess incidence. And we're lucky because we do have some good numbers on that. On a patient level, overdiagnosis occurs when the time to other cause death is less than her lead time. So for example, the elderly patient I described who had a new diagnosis of breast cancer, so her lead time is probably going to be less than her death from her lung cancer. On a population level, the fraction of overdiagnosis is determined by the distributions of lead time and other cause survival. We know from multiple statistical models the average lead time for a breast cancer is 2 to 4 years. And there was a recent summary estimate of 40 months. And 40 months has been pretty widely used throughout the breast literature as the mean lead time for a detection of a breast cancer. So then, people much smarter at statistics than me, Dr. Etzioni and her colleagues set out to check and see if they could validate that 31% overdiagnosis rate that was published and widely broadcast. So for their purposes of calculations, they assumed 100% of in situ cases were overdiagnosis. Not that they agreed with that, and not that we agree with that, but they did that for the purpose of their study. And they assumed that all advanced cancers were real, which makes sense. So a cancer that's already metastatic, we're going to assume is not an overdiagnosed cancer. They looked specifically at the localized cancers, and based on the distribution of cancers, for an overall overdiagnosis rate of 31%, 18% of localized cancers would have had to be overdiagnosed. And then using that, they calculated that based on that rate, the lead time would be 108 months or 9 years, which is well in excess of what has been established as an accepted mean lead time of 40 months. So they kind of were able to debunk that 31% using good statistical and widely accepted data. Similar calculations have been done, and these come from the trials in Norway and Sweden, where they do have better randomized trials of screening, and they find much lower estimates of overdiagnosis, in the range of 3% for invasive cancers being overdiagnosed, which is much more in line with what we as breast imagers believe could be real. In the UK, another study showed an additional 3% overdiagnosis of invasive cancer, and then understandably a much higher overdiagnosis rate of in situ disease. So overall, when we correct for the incidence estimates and the lead time bias, we can come up with a percentage of overdiagnosis that's pretty fair, in the realm of 1 to 10% of breast cancers being overdiagnosed, and that's mostly due to the inclusion of DCIS. We really need to address DCIS to kind of understand our role in this whole thing, because we know that DCIS is so variable in its behavior. You can see that on multiple autopsy studies, the incidence range from 0 to 15%, obviously a higher incidence of DCIS when more slices per breast were examined. So that would indicate there is a reservoir of DCIS that is kind of quiescent, or that we're overdiagnosing. However, interestingly, the invasive cancer incidence was 1.3%, which correlates closely with the actual disease prevalence in living people of 1%. And so in a way, this autopsy study is a direct observation that invasive cancers are not being overdiagnosed, and in fact, they do not remain quiescent in the breast until death. Perhaps the most interesting thing about this study was that this was done by Dr. Welch, the same Dr. Welch who years later went on to try to tell us that we're overdiagnosing breast cancer. To kind of, again, demonstrate how DCIS can result in such a higher percentage of overdiagnosis, we see in 1975, before there was widespread use of mammography, the percentage of breast cancers that were DCIS was about 5%, and those were all very large, palpable cases of DCIS. And since that time, the rate of DCIS has significantly increased due to the use of screening mammography. Clearly, the main harm of overdiagnosis is overtreatment. And it's because we don't have a way to diagnose currently between lesions that require aggressive treatment and those that don't. And so most women then are going to have aggressive treatment with the corresponding morbidity and cost of that treatment. And this, because we can't differentiate between lesions that need aggressive treatment and those that don't, results in a lot of patient and provider confusion. That's very understandable. So I had to include this quote because I like it and I hate it. This was in Radiology in 2013. And they say there's no such thing as overdiagnosis. There's only correct, partially correct, or incorrect diagnosis, right? If abnormal findings are diagnosed correctly, then there is only optimally managed, suboptimally managed, mismanaged, and possibly overtreated disease. And I'd kind of like to just nod my head, and I see a lot of you nodding your head also, that we, and kind of agree with this. I think, along with what Bib was saying, we need to accept that we are not blameless in this. It totally diminishes our value as radiologists if we place all the responsibility for overtreatment on the users of our reports. So we need to accept that we're part of this to make sure that we don't diminish our own clinical relevance and overall value as radiologists. So as such, I'd like to kind of go on and describe the role of radiologists in managing overdiagnosis, and kind of talk about both future, how this will be managed, and what we can do today. Obviously, our goal is to treat those women who will benefit the most and minimize morbidity to those who benefit the least from the treatment. In the future, there's going to be, I believe it's going to be fantastic for breast imaging. We're going to have additional molecular markers that will help guide us based on our biopsies to know which patients need to go on to have aggressive treatment and which women do not. We're not there now, but I certainly think we will be before I'm done practicing. There are currently ongoing trials of watchful waiting, and there's a whole developing field of imaging that there are people in this audience, I'm sure, who know more about than I do, of radiomics. The ongoing trial of watchful waiting is the LORIS trial in the UK, and this is specifically evaluating low-risk DCIS, and that's where we just kind of went through and admitted that yes, probably that's where the source of overdiagnosis is, and they're randomizing women to either standard surgery versus active monitoring with annual mammography for 10 years at least. And they're evaluating the physical and psychological effects. You know, not just is it medically okay and the outcomes are similar, but is it, you know, okay for a patient to live with knowing she has DCIS and not excising it from her breast. So that's a very exciting trial to kind of watch for the outcome. I believe they're 2 or 3 years into that now. And then there's this field of radiomics, and this is really the extraction of large quantities of data, more than meets our eye as a radiologist, from PETs, from CT, from MRI, and we can then use a region of interest or even a habitat within a lesion and extract data in a non-invasive manner and combine that with clinical and genomic data to then generate some predictive and prognostic models so that maybe even without biopsy of some of these lesions, we can determine the best treatment for those women. So that's big picture in the future, but not very helpful for you going back to work tomorrow or Monday. So I have 5 items that I think we can all take back, and I know that some of you don't do any breast imaging, but you are all radiologists, and as such, probably at least a neighbor or someone, a family practice doc, might ask you your opinion on these topics, so I think it's important for everyone. The main thing we can all do is be comfortable with the conversation, both with your patients and your referring providers, about the benefits and potential harms of screening mammography. We really, again, as Bib was saying, we put the patient in the center of this, and we recognize that they all have unique risk factors and a unique risk tolerance, and that might not align with our own. That really puts the patient in the middle, and to be comfortable talking with them about their feelings of this and what we think is an important conversation to have. We've really moved away from the recommendation that she's 40, she needs a mammogram every year. We don't do that anymore. But to be able to have this conversation with patients and have a kind of an understanding of the various recommendations is extremely helpful. I believe you'll probably hear more about that from Julie or Jill. But to know and be able to tell a patient that even though all the societal recommendations differ, all of them do agree that screening mammograms beginning at age 40 saves the most lives. They all agree that. If you read the fine print of the USPS task force, they will say beginning a mammogram at age 40 saves the most lives. What they disagree on are the weight of the potential harms. And if you can talk with a patient specifically about those harms and admit that yes, we might find a low-risk breast cancer that doesn't really pose a threat to your life, if you can feel comfortable talking about that, you'll have a much greater value to her and to your colleagues. The second thing we need to do is to be aware of the effect of age. At the extremes of age, obviously in the older patient population, comorbidities increase significantly. And so there's an increased chance of finding a slowly progressive tubular or low-grade DCIS that really possesses no life-threatening risk to that patient. On the flip side, in women younger than 45, there's a much lower background incidence of breast cancer, and therefore the potential harms are much greater. Of course, the potential benefits are much greater too, because if we find a localized invasive cancer in that woman, there are many, many more life years saved. Third, we need to identify our high-risk groups. And if your practice doesn't have a way to identify those women who are truly high risk, I would encourage you to do that, because in these women, cancers are more likely to be high grade, and overdiagnosis is very unlikely in any of these women. 4, I would encourage you to use the best technology available to you. You're going to hear later this morning about tomosynthesis. I know it's not available everywhere, but where it is, we know that tomo improves the net benefit of screening because we find more invasive cancers without increasing our detection of DCIS. So while we're not decreasing the risk of overdiagnosis, we're improving the net benefit because the cancers we do find are cancers that matter. And 5, you should be aware of the competing pressures on one hand of finding more cancers, and 2, minimizing the harms of screening. And specific to this, I'm thinking about breast density notifications, as these laws have been put in place around the country. They're encouraging, some of them, women to undergo supplemental screening tests, such as ultrasound, and we know that supplemental screening will find more incremental cancers, but we have no evidence-based medicine that says finding these cancers in a non-high-risk population actually results in improved outcomes. So to keep that in mind, on one hand, that you're getting push from some patients and some sectors that you should be doing more testing and finding more cancers, and at the same time you want to minimize the harms of what you're doing. We just need to be cognizant of that and make sure that we continue to promote the use of proven technology, and that is specifically that screening mammography is the only screening modality in breast imaging that has been found to improve the breast cancer mortality. So lest you think this is a topic that's important only to radiologists and epidemiologists, a little Google search will turn up several articles, including this one that was in Forbes. I do not know who Elaine Shatner is, but she's pretty pro screening mammography and pro radiology, so I think I like her. This advice is what she gave women in her article. She said, have your screening mammogram read by a breast imaging specialist. We know that's not possible. There are plenty of general radiologists who do a very good job of reading mammograms, but we as radiologists need to make sure that we continue to make sure we're refining our skills and doing the best possible work. She said that you should realize that overdiagnosis is not the same as overtreatment, and I really love that she made that point because that's very true. And 3, she encouraged women to invest in better screening and to have a tomo exam if it's available to her. And to have an MRI if she's truly high risk. So this is out there in the general population as well. So in summary, overdiagnosis does exist, and it is a potential harm of screening mammography. The estimation of overdiagnosis is susceptible to bias in determination of both the excess incidence and the lead time. But when we correct for those biases, the extent of overdiagnosis likely lives somewhere in the realm of 0 to 10%. Our role today in managing this, really, these are the 3 points I'd like you to remember. To be comfortable with the topic and discuss it with patients and clinicians. Make sure you're adding value to those people, to those patients and to your providers. Be sensitive to the extremes of age and screening, high-risk groups, and individual risk tolerance, and use the best technology available to you. So that is all I have for you. I'd be happy to answer any questions that you may have. Yeah.
Yes, I was wondering if you could comment on, in your practice, how do you handle individual risk analysis for patients? Do you leave it to ordering clinicians, and if so, is it actually performed in the majority of patients?
So interestingly, I've been involved for probably 2 years without a ton of progress in kind of a system-wide approach to screening centered around shared decision making. So it's a concept familiar probably to all of you. And the idea was that there are health maintenance reminders in Epic and probably in whatever electronic record you guys use. And there was discussion about whether they should turn that on annually beginning at age 40 to remind patients, or at 45, and should it go every other year? And those discussions have been very difficult. But part of that is that clinicians tell us they do not have time in an office visit to sit and actually do that shared decision making. So we would love to be more involved in making that decision with women, but we can only take care of the people who are already there. They've really made up their mind already to come for screening. So in my practice, we do have that conversation quite frequently with women who are there when they're not sure whether they want to come back next year or not. But I don't have a great way to reach women who are 40 and are not sure whether to come in or not. Our system is looking at implementing a screening tool that would be available through the patient portal, and on the clinical side and in radiology, where the patient could input her own data and come up with kind of her risk score, but that's not there yet. Yeah.
One thing I had read, now this was a while ago,
Yeah.
but that there was, if you're thinking about overdiagnosis with DCIS, there's a distinction between DCIS that's diagnosed on a first mammogram
Yes.
versus DCIS that's diagnosed on a subsequent.
Yes.
Is that what you found?
That is what I found also in reading that, in preparing for this talk, that DCIS that is found on a first screening mammogram is more likely to be an overdiagnosis than DCIS that pops up on a subsequent mammogram, because that is a change and something that is showing some sign that it is actually maybe progressing. And I don't remember the actual stats, but that is something to kind of keep in mind, that DCIS, if you do have a 6-year-old who comes in for a baseline and you have some calcs and you biopsy them, that that she may have a higher percentage of being an overdiagnosed DCIS than a threatening DCIS. Yeah.
So do you put those calcs, like questionable, indeterminate calcs, in 6 months or 1 year follow-up? Do you put with the mag views?
Yeah, so, well, first you always have to do mag views, right? You can't give something a BI-RADS 3 without working it up. As screening recommendations have changed and we're becoming less certain of when women are going to come back, I personally feel like I'm more erring on the side of taking care of it now. If I'm not sure she's going to come back for another 2 years, because that is an acceptable interval based on a lot of screening guidelines, I'll have that discussion with her, but I'll say, I would prefer to biopsy these now and know. Yeah.
So then that's where the overdiagnosis, because you have the first diagnostic, you're making your decision.
Yeah. Yeah. Anything else?
Do you let the calculated risk, say if you have the BCRA risk percentage, do you let that sway your decision at all?
In terms of whether I biopsy something or not, I don't think whether I let something, if they're a known BRCA mutation carrier, we know that we do, that does sway me. So if I see a small area of enhancement on an MRI, there are studies that show that that's more likely to be positive in that patient population than in a general risk population. So that does sway me, but if it's just that they have a higher lifetime risk, I guess, well, to say that it doesn't sway me is wrong. I should retract my first answer. It does come into my mind. But also, not just because of what I'm thinking about it based on its appearance, but because I know that patient has probably a greater anxiety. So if she has a mom and a sister and a grandma with breast cancer and she has new calcs, I might think they're very likely to be benign based on their appearance, but because of her risk, that you're right, that does sway me.